Jan Strasse, Frank Strasse, sorry, asked me to give you this lecture regarding inflammatory heart disease. I understood you are first year students or master students. Have you been in the clinic already? Not a lot, from what I understood. And he asked me specifically for this lecture to give you a little bit more clinical side of what you've been seeing. And from what I understood, in a few years or this year already, you will be going into the clinic. Maybe you see a few of the patients. In the end, I also have a few cases if you have time left, and if you are not that hungry for lunch, then you can go through those also. I'll start first a little bit about heart failure in general, and then I'll specifically go into inflammatory heart disease, and then specifically viral heart disease, immune-mediated heart disease, and a little bit about therapy, what we can do for these patients at this time. So we all know the heart. It's from the cardiology standpoint, as we say, it's the most important organ that we have, but we have to say that's always the heart, or the brain. With rhythmic contractions, as you can see here, the heart pumps the blood through the whole system, and then you can have enough blood and oxygen supplies to the muscles, organs, so that you can function normally. What happens if the heart fails and the motor doesn't work, and then patients get the dyspnea, as you can see here. These are classic patients that you see here. One is more the left-sided heart failure, that's the person sitting in a chair who can hardly get any breath. As you can see, his chest X-ray full of fluids, so all the ventricular fluid, there's no oxygen, no air, so that's why this patient is sitting there and gasping, is short of breath. Those are the classic patients that we see. And also the patients have more right-sided heart failure. These are the patients who retain a lot of fluids. You can see that in their legs, their arms, and then you can see this lady sitting there with the distended abdomen, especially the legs and the arms. You can see edema. And these are the classic patients that you see with heart failure. This is an end-stage heart failure. These are the patients which usually come to us in the later stages. You all know heart failure that has a lot of causes. The most known cause is myocardial ischemia, a heart attack. Let's say about 80 to 90% of all patients have had a prior heart attack. As you can see, the coronary artery disease here. These are normal arteries. You can see atherosclerosis and eventually plaque rupture, and then patients get a heart attack. And depending on which vessel it is and where the heart attack is, depending on how the clinic will be later on. Also uncontrolled hypertension, which is the wall thickening, and then you get more dystolic function, and those patients also have heart failure in the end. Patients with valvular heart disease, with aortic sclerosis, here in Europe, you see that in the modern society. This is actually the same pathogenesis as atherosclerosis, but that of the valves. So these patients get especially aortic valve stenosis. And then eventually the same pathogenesis as hypertension. They get a very thick left ventricular wall, and then eventually diastolic heart failure. As I highlighted here, virus infections and systemic diseases, those are less known, but these are also very specific causes for heart failure. Modern days, we have a lot of cancer patients. We give them specific therapies, and also these therapies are good for the cancer, but also bad for the heart. And these patients, these are especially cardiotoxic medications. But I'll focus a little bit on the viral infections and the systemic diseases. And there we go on, and those are the group that we call the inflammatory heart disease. This is a slide with a lot of text, but actually inflammatory heart disease, to keep it simple, is just inflammation of the heart, and depends on what may be the cause. You see, inflammation of the heart is usually the infectious agent, usually viruses or bacteria, not that much in Europe, but also autoimmune diseases we see more and more present. And inflammation can be everywhere in the heart, because if patients get a myocardial infarction, it's especially the cardiomyocytes that are damaged. But here we also see the myocyte, but all the interstitium, endothelial cells, and the pericardium may all be involved. And it depends on where it is, because these inflammatory cells are not the same as the heart attack. One vessel is occluded, you get a specific area, but these inflammatory cells may be throughout the heart, and depending on where it is, where the inflamed cells are, where the eventual myocardial necrosis happens, that also depends on what the clinical of these patients are. So it may be diffuse, it may be local, and it may also be chronic and acute. So that makes it very difficult for us. If we say inflammatory heart disease, it can be active in myocarditis, that's just inflammation of these myocytes. It may be a prior myocarditis which has healed, is healing at this time, or we have inflammatory cardiomyopathies, and we call it with viral persistence. We see any viruses there without or with persistent inflammation, with both, and we can eventually get a dilated cardiomyopathy, that's end stage, where it could be due to a prior infection or ongoing inflammation. So for us it's very important to differentiate which part and which stage the patient is for us to tailor our therapy for each patient. The problem is we see a lot of patients and they all have specific symptoms. They may be asymptomatic, they may have chest pains, arrhythmias, palpitations, they may present with heart failure, they may present with extreme heart failure, fulminant heart failure, and they can have any or none of these symptoms. And with the clinic, we cannot distinguish which group these patients are. And these patients, depending on which group they are, they may also develop in all stages. They may recover completely, they may be asymptomatic and recover. We don't see those patients. These are the patients that go to a general practitioner and stay home. Or they may come to us in a later stage where they already have heart failure. And they come to us in the early stage where they have palpitations or chest pains and they may recover completely, or patients may die. There's been a nice study recently from young students with the University of Nebraska. They have 20 years. They have all sudden cardiac deaths of young students, and most of them, 40% I think, had inflammation of the heart, and then probably arrhythmias and then sudden cardiac death. So the inflammation is something that we do not see because patients may stay out from the cardiology department. And patients with extreme heart failure, they may die very soon if you don't intervene quickly. The same as the clinical diagnosis, we cannot say anything. Patients may present with a broad range of symptoms, and if they have inflammation or no inflammation, we cannot see any difference in these patients' groups. So we need to look a little bit further. We can make an echo of the heart. That's also helpful, but it doesn't tell us anything regarding the inflammation. These are very aspecific symptoms. There are no specific abnormalities. They may have systolic and/or diastolic dysfunction. They may have a dilated left ventricle, or they may have pericardial effusion. But all these are very aspecific, and we know if it's a fulminant, if it happens very quickly, then the heart doesn't work at all. So there's no dilatation. Dilatation is usually the fact that it's chronic, and then the heart needs to work harder, and then the heart remodels and dilates. What we do see is an LV wall. It's very not specific with hypertension. It's just one wall that's thickened. That's not due to a thick or due to myocardial hypertrophy. It's due to edema, which we can see, and we see a diffuse hypocontractile heart. I'll show you an example later on. If it's subacute, then we see the dilatation, and then we see a slightly decreased. But these are all clinics, but the patient that has a myocardial infarction may also have these similar abnormalities on the echo. Modern day, we also have the cardiac MRI. This helps us a little bit more. We have two modalities which we use, the T2-weight and late enhancement. And the T2-weight is for edema, and late enhancement is more for fibrosis. And that can help us, especially the edema. If you see edema, that's something that you only see in inflammation. And here is a little bit more, which helps us especially to identify inflammatory heart disease, because we know ischemia. We know that coronary arteries are on the outside of the heart, going to the inside. So if it's occluded, or if it's stenotic, then especially the inside is damaged first, and later on the outside. And if it's completely occluded, then you get a transmural heart infarction. This is typical for a myocardial ischemia. If you have mid-myocardial or epicardial late enhancement, fibrosis there, and it's something that cannot be done due to the occluded vessel, because no vessel is from the inside to the outside. This helps us to differentiate if there's an inflammatory heart disease. Because if you can see here, there are a lot of causes. This also can give these specific patterns on the cardiac MRI. These are these pictures look when we see those. And here you can see ischemic, and you can see the endocardium is enhanced. It's a late enhancement, that fibrosis there. And here you can see in the mid wall, and you can see uptake. That means it's mid myocardium. So that's helpful. This is a patient also with a bad heart. Both have bad hearts. This one here is not due to myocardial infarction. It's due to something that's probably due to inflammation going on. So the clinical diagnosis is not sufficient. It doesn't tell us anything regarding the symptoms. So we need to look further. And I'll go on a little bit later regarding endocardial biopsies. First, I'll tell you a little bit more about the pathogenesis, and then I'll tell you what we are looking for in these biopsies. Usually we say that inflammation is something that's all patients have. It's all or nothing, but we don't see that. It's a genetic predisposition, and then there's a certain immune response that the patient gets that has a certain trigger, probably the viruses, and these patients in the middle, which have this predisposition, which have an exuberated immune response due to the trigger. Those are the patients that develop heart failure. You have patients that have a genetic predisposition without an immune response. They don't get heart failure, or the patients with a certain immune response but which never get the trigger, those also stay stable. Because it's a very complex picture, as you can see here. Cardiotrophic viruses, they may enter the heart. Okay. And we have certain viral receptors in not only the heart but in all organs. But I'll focus now on the heart. And then the virus can enter the heart. Let's keep it simple on this side first. And then they enter the cardiomyocytes or the endothelial cells, and there they can replicate themselves, and they cause cellular dysfunction and eventually ventricular dilatation, myocardial damage. And that's one part of the cyclus. The other part is actually the more important part. That's the activation of the immune system. And the virus enters the heart, it activates the immune system. That's a natural response, because if you get the common flu, your immune system is also activated. And then you get the upregulation of the T cells and your B cells, and then you hope that your immune system eliminates the virus, and then you're in a week with a stiffy nose, you're healthy again. But if this immune system doesn't downregulate, or you get an exuberated upregulation, this response on probably the simple virus infection may cause also this damage. So it's not only the virus application or the autoimmune system, I think it's a combination of both. And it's hard to differentiate which patients will respond in which way. So, and that's why we need to look at in detail what happens in each patient, and that's why we take endomyocardial biopsies in the patient that has the exuberated response, the patient with heart failure. You can see that it's an inflammatory heart disease. When you look at the cardiac MRI, look a little bit further, is it more an autoimmune disease, or is it more due to the viruses? Because you cannot treat both at once. You need to specifically look at the groups. So we take cardiac biopsies through the jugular vein. We enter the patient to go into the heart, as you can see the picture. And then we take some small samples of myocardium, and that we analyze further. Complications of this procedure are actually very uncommon. If you do it in a center that has a trained cardiologist who does this not daily but weekly, the complications are very low. But the most feared complication is that we don't take a sample of the endocardium, but eventually perforate the heart and also take the epicardium, and eventually tamponade. I don't know if you know what that is. So that means blood in the pericardial sac. and when due to the pressure overload, the heart can't contract anymore. So that's a very complex complication, which we have to have only once, I think, in 1,000 cases. So it's very rare, but if it happens, that's the most dangerous complication that you get. All the others are not good, but you won't die, so to say. So these complications are rarely encountered if done due to a specialized cardiologist. We get these samples in our lab. These are these tiny microscopic myocardial biopsies. We take I think around 7 to 10 samples per patient. And then we have standard staining. That was the classic Dallas criteria. Now we did the H&E staining, and then we can see if there's myocyte infiltration or myocyte necrosis. And if there wasn't any necrosis, then we would call it a borderline myocarditis. These were the classic criteria. As you can see, they were from 1987. And this is a classic staining, as we can see here. You can see normal cardiomyocytes, and you can see artery containing inflammatory cells. You can see the inflammatory cells in between the cardiomyocytes. But we do not see myocyte necrosis. So this would be a borderline myocarditis in the classic criteria. As we also saw in the MRI, especially inflammatory heart disease is very patchy. It's not specifically one place, and we do not take biopsies all over the place. So we have the problem with this one is that we took specific samples from the right ventricular septal wall, and we had a large chance of getting sampling error. So that was the problem with the Dallas criteria. Here we have a classic case of a fulminant myocarditis with myocyte necrosis. As you can see, these dark myocytes here compared to those, these are dying cardiomyocytes. So this would be, according to the classic criteria, a acute myocarditis, and the prior was for a borderline myocarditis. What we also could see in patients with acute heart failure was the lymphocytic myocarditis. Is the picture that you just saw. The giant cell myocarditis is actually the same, but then with these large lymphocytes where they group, because if they work alone, they can't respond or they can't eliminate the trigger. Then they say, let's work together, and then you get these clusters of better anti-inflammatory cells, lymphocytes, or you can get the eosinophilic, these classic pictures here, eosinophilic lymphocytes. These are all causes of patients with acute heart failure. A normal healthy person, and that patient deteriorates within a week or 2 weeks. These are all classic, especially these last two, giant cell myocarditis and eosinophilic myocarditis, are causing extreme heart failure in a very short time. But that was the problem. It gave a lot of sampling error, low sensitivity, and it was dependent on which pathologist looked at it. There was a lot of inter-expert variation, but it did not tell us what the trigger was, if there were any viruses or other immune markers present, and it did not have any prognostic value. So that's why later on, criteria to take biopsies was that we must have an incremental value, especially the diagnosis. That's why we performed immunohistochemistry, so we can get specific antigen stainings. Here we can see all these brown spots. Those are the immunohistochemistry, and these are in this case CD3 staining, T lymphocytes. And you can do all specific stainings regarding T cells, B cells, CD45, that's the common antigen for our lymphocytes, and CD68 was for macrophage. And these had greater sensitivity and also had a very good prognostic value in which person would eventually have the worst prognosis compared to the one without any inflammation. And these were the classic criteria where we had the Dallas criteria, and these, since we have the immunohistochemistry, these changed, and now we can say fulminant myocarditis. We have a lot of inflammatory cells, more than 50 per square millimeter. Active myocarditis is more than 40, and necrosis is likely, as you can see in the first picture that I showed you, without the inflammation, without the cardiomyocytes deterioration or necrosis. if you have a lot of inflammation, you still call it an acute myocarditis. And the chronic active is also inflammation without especially the myocyte necrosis, and we have chronic persistent. We also do specific viral assessment with PCRs in biopsies, and there you can see patients with acute myocarditis or with myocarditis in the past. You can see that a small portion is virus negative, that's the green part, and then see over a larger portion it has viruses in the heart, and especially the parvovirus B19 is very common, especially since I think 2005. Since this group presented it, we've been looking more for these viruses, and the human herpes virus 6. If you look at your textbooks, most of them say enterovirus and adenoviruses, and those are the common viruses that were earlier on, but these were also very little present in these groups. This is also because in the past they did not look for these viruses as parvovirus and human herpes virus. And the nice thing about this slide was that patients with eventually dilated cardiomyopathy, which was not caused by ischemia, who they suspect as patients to have inflammatory heart disease, they see the similar portion that these viruses were similar proportion present in the heart. So they suggested that patient had an acute inflammatory heart disease due to viruses and virus persistence, and eventually developed dilated cardiomyopathy. But we don't only see the viruses present, we also quantify them. And there is a nice publication on the book. In the patients group with acute myocarditis, they see that the inflammatory load, or virus load, is extremely high, it's over 300,000. The patients with chronic or dilated cardiomyopathy also have an increased load, not as high as the patients with acute myocarditis. And that the control group had also virus present, but it's very low quantification. Besides the virus load, we can also quantify these viruses in the heart. And we have specific parvovirus stagings, and then we can see that it's not only present in the heart, but it's also actually infecting the heart, as you can see here, where it's located in the endothelial cells. Parvovirus B19 is known to attach to the endothelial cells. Besides the immunostaining of parvovirus, we also have capsid proteins, which we can stain. The parvovirus has PP1 and a PP2 capsid. We can quantify those, as you can see here. Similarly, in the endothelial cells, those PP1 and PP2 we can stain, but also in cardiomyocytes they may be present. So this further suggests that the parvovirus is not only present in the heart, but actually infects the endothelial cells of the heart and the cardiomyocytes themselves. I'll have tell you a little bit about immune-mediated heart disease, but not a lot. We looked here at a group of patients, control group patients with ischemic, inflammatory heart, with dilated cardiomyopathies, and which were dated as inflammatory heart disease. And we looked at patients with immune-mediated heart disease and patients without immune-mediated heart disease. And we looked at specific inflammatory heart diseases which were present, vasculitides, selective tissue diseases, and rheumatologic disorders, and diverse heart diseases such as sarcoidosis. All patients had bad hearts. This is the nice thing about this slide was, as you can see, the control group, they had soluble interleukin-2 on this side and the parvovirus copies here. In the control group, both were low, and in the patients without inflammatory heart diseases, without immune-mediated diseases, you can see that the inflammation in the soluble interleukin-2, that is a T receptor in the serum. You can see that is compared to the normal group, and the parvovirus was especially high. So this group is more due to virus-mediated heart disease, while the patients with an immune disease, they had present virus a little bit higher, but compared to the control group, similar, but these had an extremely high soluble interleukin-2 level, also compatible with their immune-mediated disease. So you can make a differentiation between a more immune-mediated disease or more viral heart disease. So then we have patients who have an acute viral or a chronic infection. they develop inflammatory heart disease, and we take biopsies, and then we can say there's inflammation or there's no inflammation, and then we can specify even further if there's persistent viral persistence or no viral persistence, and then we can quantify them if we have a post heart disease without any traces of active inflammation, more the viral persistence, where there's viral heart disease, or more the autoimmune heart disease. And we need to differentiate those because we need to see which way we need to go regarding therapy. And then we have specific immunosuppressive therapy and specific antiviral therapy, and that's why we need to look at which group we need to treat. And these are older studies done where they gave patients with HLA, with dilated cardiomyopathies, and patients with an HLA expression, which was suggested in more immune-mediated disease. And then they gave those patients placebo, or they gave an immunosuppression regimen regarding prednisolone or azathioprine, and in adequate doses. And these patients were followed for 2 years. At that time, the viral diagnosis was not really performed. And then you can see that the immunosuppression group did show an improvement of the left ventricular function in 2 years, as you can see here. Compared to the placebo group, they also improved a little bit, but compared to the immunotherapy group, the improvement was much more. But that was actually a secondary endpoint. The primary endpoint was death, heart transplantations, or cardiac hospital readmission. And then you can see there was no difference. So there was actually a sub-analysis which showed that. So, but they did show that immunosuppression in the group, which the HLA expression results in an improvement in cardiac function. This is a more recent trial from Professor Frastaschi in Italy, where he looked at patients with dilated heart failure, unresponsive to conventional therapy. They also took biopsies, and then they selected patients with inflammation, but without the presence of viral genome. So that's actually the autoimmune group. And that group he treated also with a very high regimen of immune suppression. And then also he saw an improvement in cardiac function, and the placebo group did not improve at all. So also suggesting that immunosuppression works in this group. As you can see also it was 85 patients, so a very small group of patients. Then there's the antiviral therapy. These are more specifically for patients with inflammation with presence of viruses in the heart. They treat them with interferon beta in extremely high doses, 8 million units, or placebo. And they had 3 groups, 4 million, 8 million, I think, and 12 million, but I'm not sure. And then they saw in the patients with had enso or adenovirus that they improved a little bit, and the patient with only parvovirus did not improve as much, because it's known that the interferon does not work as well on the parvovirus, but they did see an improvement overall. This study was presented in 2009, but we're still waiting for the publication, so I'm a little bit skeptical regarding the actual results. But they did see a global improvement, slight improvement in the interferon group, especially the high treatment groups. But we have no other data, but we're still waiting. I don't think they will ever present us the official data. There are also immunoglobulins. Those are specifically against specific viruses, but immunoglobulins also have an upregulation of your immune response, especially antiviral pain groups. So on patients with recent onset cardiomyopathies, they also gave patients high doses of immunoglobulins, and they did see that there was cellular inflammation in the heart, but they also did not do any viral diagnosis in that time. And also you could see that both the conventional and the placebo group, they both improved. So in patients with recent onset heart failure, immunoglobulins do not work if you do not further specify groups. So it's a small group that we actually looked at here, patients with inflammation, with high viral load, especially parvovirus B19. And we selected immunoglobulins with a high titer against antiparvovirus B19, and we could see improvement. It was also a non-randomized trial, so we're currently investigating this in a larger trial. So as you can see, for us it's important to differentiate between inflammatory heart disease, to see if it's more viral or is it more autoimmune mediated, and then we need to titrate our therapy regarding more specific antiviral therapy or more specific immune mediated therapy, and then we can hope that we can help patients a little bit better. This is our group. Especially Professor Heijmans here is known to do a lot of work on the inflammatory heart disease in the clinic and also in the pre-clinic. And as you can see here, it's not only the cardiology department, also the microbiology, the immunology, and the pathology, which make a large part of our group. Are there any questions at this time? I would like to go through a couple of cases with you. Maybe one of the most important case, and then you can see how it's actually goes in the clinic. You can see all these data, because it really gives you an impression of how it's like when you see these patients. 32-year-old female, actually mother of two, presented to us I think 5 years ago when I just started working here. She had no prior medical history, always healthy. And then she had some flu-like symptoms prior to her admission. And then she had some typical complaints where she were persistent, dependent chest pain, and that we see when the pericardium is also involved. The patient gets pericarditis, especially when they take deep breaths. There's a little bit of stretch on the pericardium, and then the patient can have some pain symptoms. So that's actually how the patient presented herself. Every patient with chest pain and goes to the general practitioner is always referred to the cardiologist. This was her electrocardiogram at admission. I don't think if you ever seen electrocardiograms before. Okay, this looks quite normal, so to say. She does have specific abnormalities here and here. It's called PTA depression. Normally you have a baseline like this, where it's on one line, and here you can see that this is depressed compared to the baseline here. That's called PTA depression. That's also typical symptoms which we see in patients with pericarditis. We see a lot of these patients, and usually this is self-limited. So then we just admit patients, or we wait, depending on how they are clinically, and then we follow them up. But at this time, she had no fever, she was stable, she had no classic pericardial block. Can hear a nice friction, but we did not hear it. But this was disturbing at that time. She had a troponin T of 0.7, which is increased. That's a sign of cardiomyocyte necrosis. There's decay of cardiomyocytes, and she had a large increased CRP, the C-reactive protein, is also a sign of inflammation, and also her white blood cell count was increased. So we had sign of inflammation, and we also had signs of cardiomyocyte necrosis. If the troponin T was normal, then the patient would be discharged, and we would follow her up later on. But due to the increased cardiomyocyte necrosis, distinguished with heart infarction, while there is myocyte necrosis, there's a chance to develop arrhythmias. Those are the patients who never present themselves at the hospital. Those are the patients with sudden cardiac death. That's why we always admit patients at that time. While the inflammation is ongoing, patients are always monitored. We made an echo, and there we saw a global, slightly decreased ejection fraction. Normally it's 55 and up, now it's 51. It's nothing really disturbing, only that she had some myocyte necrosis. So she stayed with us for one more day, and we made a cardiac MRI. And then you can see the same abnormalities, the T28, and you can see a large portion here of edema. And same as goes here, it's the lead enhancement. So she had a typical sign, not only pericarditis, but also myocarditis, that was compatible with the biomarkers which she had with myocyte necrosis. While she was with us, within the next 2 days, she deteriorated. The black screen keeps popping up. This was the echo at admission, and this was the echo a little bit later. What you normally see is the heart contracts, and then you can see this nicely coming in. That's how the heart usually works. And as you can see here, that she is one, she's tachycardia. That's a sign of shock. And as you can see on this side, you cannot see the nice contraction of the heart here. So her ejection fraction fell to around 15%. So this patient was in shock at that time. As you can see here also, the EKG deteriorated. As you can remember, the first EKGs did not have the right bundle branch block. Everything is broadening. So not only on the echo, but also electrocardiography, you can see that she's deteriorating very fast. That's why we take biopsies, because we know that a classic myocarditis or pericarditis is not all patients deteriorate. We wait 48 hours to see how this patient goes. In this case, she deteriorated. That's why we took some biopsies. We had no inflammation at that time, the classic Dialis criterion, but she did have a CD45 cells increased, which is more than 14, more than 12 in this case, which was 26. And she also had a very high parvovirus B19 load in the heart. So at this point, we said the trigger was probably the parvovirus. And then she had an extreme immune response on that virus, and that way she had her heart failure. As we can see here, the troponin T was increased enormously, 4.1, and also other markers were increased, also a sign of extreme cardiomyocyte decay, and also the liver failure also happening. She's always in shock. So due to the fact that we had a patient with an exuberant immune response, also the virus, that's why this patient we gave a combination therapy with both immunoglobulins and immunosuppressive therapy, but the cardiac improvement stayed out. The patient was that bad, she eventually needed a assist device. If you've seen this before, this is a pump which we put in the apex and goes to the aorta. And your left ventricle usually does that. Blood comes into your left ventricle and pumps it to the aorta. And if you have a heart that doesn't pump anymore, we apply this pump where the blood can come to the pump, and the pump pumps it to the aorta. This is a last resort for patients. If the patient with all therapy does not respond. If you do not do this, the patient will die at that time. This is not a very friendly therapy. It has a whole lot of complications. But it is, as she is 32 years old, your only option at that time. In the hope that you can wait and take more biopsies, more diagnosis. This is the biopsy performed while we placed the LVAD, and then you can see here, which we did not see at the first biopsy, here we see the giant cells. So the immune response went from normal lymphocytes, in this case, to giant cells, where they cluster and cause even more damage. And I can hardly see any normal cardiomyocyte here. All cells are actually dying or decaying, and exuberant inflammatory response here. With the assist device, she eventually stayed, I think, 6 or 7 months with the pump, with all complications, and then a heart was available. I think 7 months later, we had an uncomplicated heart transplantation, and is currently walking around. So it depends really on which way that you go. You have a lot of scenarios. This is the worst case scenario in the patient that we could help. But a lot of these patients, if she stayed at home and stayed with her kids and did not present to the general practitioner, I think she would have passed away at home. So as you can see here, I think 80 or 90% of all patients with myocarditis, they recover spontaneously, but you have these cases which are extreme. And we need to look at the therapy, which way we need to go. In this case, it didn't matter what we did, the patient is recovery. So that was this patient case. I don't know, you have time for another one, or it's one break? One more? Okay. This is a 53-year-old male presented here, I think month ago, I saw this patient. Very strange to have been diagnosed with type 1 diabetes in 2009. The patient was 50 years old. You hardly ever see type 1 diabetes in patients above 25. And at that time also hyperthyroidism at that time. So he had two immune phenomena presented at a relatively late age, this patient. We see that he also presented with acute chest pains, also flu-like symptoms, similar to the first patients. These patients are usually like this. This is his EKG, similar as the first patient, almost normal, but you can see PTA depression here also suggestive of with this chest pains, of pericarditis. Currently we have the high sensitive probability, which is increased also, and you can see here is a normal left ejection fraction, and they had also pericardial effusion. It's also suggestive for pericarditis. But in this case, perimyocarditis, because there's also signs of myocyte necrosis. So a simple case of perimyocarditis. This was a patient in Utrecht, which was referred to us later on. He is treated classically with aspirin and colchicine or anti-inflammatory regimens. These you can give in the first or second line. And this patient was discharged there, and he presented 2 weeks later with progressive dyspnea, and they could also see that his cardiac function deteriorated, but his pericardial effusion decreased. So it was not due to more effusion. But the alarming symptom here is progression under your conventional therapy and also a decay in the cardiac function. So the patient was admitted to us, and then we also made a cardiac MRI. And this is a very nice MRI where you can see here, almost similar to edema and the mid-myocardial rate enhancement here, suggestive for myocarditis. Here, which you did not see at all the prior MRIs, is the pericardium is increased here. It's very white. So this patient had dyspnea not only when we did the MRI, his cardiac function was normal, but the video doesn't work. And then you can see it's very common shuffle, when the heart contracts, his pericardium, the septal wall has a specific bounce. It's due to the cardio pressure overload in the right ventricle, and the pressure goes to the left ventricle. So that's called a constrictive pericarditis. Usually the pericardium is very stretchy. So when the heart expands, the pericardium also expands. If it's like this, that's why I call it a Panzerheart, so to say. So an armored heart, and the pericardium is very thick, it does not expand, and then the patient has increased pressures in their heart. And that is a very dangerous sign, because these patients also collapse. Here he has signs of moderate heart failure, also slight signs of inflammation, but it was 2 weeks later. Biopsies were performed. You can also see inflammatory cells, and CD45 stains were also positive, with increased inflammation, and also a slightly increased parvovirus load. But in this case, because the patient had type 1 diabetes 3 years ago, and hyperthyroidism, we did some immunohistochemistry and some immunologic immunologic lab in his plasma. And then we can see the ANCAs are positive, especially the MPO ANCA, then the ANCA vasculitis. So it's probably due to a vasculitis which the patient has. And the soluble interleukin 2 receptor is increased. It's usually below 500, in this case it's 7,000. So this patient has an exuberated immune response, and not so much the inflammatory response of the virus itself. So this patient has a constrictive pericarditis, probably triggered by the parvovirus, and he is also treated with antiviral therapy and immune suppression. And we need to see how he responds. The problem with the armored heart is that it's always, in most cases, it's permanent. So this is a 50-year-old personal trainer he was who cannot do any exercises anymore. So it has maybe started as a simple flu, common cold, but it has a lot of complications later on for his whole system. So, any questions?